Well, the second part of this guidelines presentation deals with how to achieve the blood pressure targets recommended by guidelines. And in all hypertensive subjects, the guidelines recommend to have lifestyle measures whenever they are needed. And there is no substantial element of novelty in this. The guidelines measures are the same which were recommended in the past, perhaps with the addition of avoidance of drinking, salt restrictions, vegetable diets, body weight control, aerobic exercise, and smoking cessation. And these measures have strong evidence that they can modestly lower blood pressure, but in addition to this, that they can facilitate the effect of antihypertensive drugs, reduce cardiovascular risk by variable means, and with the drawback that, unfortunately, persistence of lifestyle measures and adherence to lifestyle measures over time is poor. So, other means are needed in the majority of hypertensive patients in order to achieve blood pressure control. Guidelines do not recommend routine use of device-based therapies, that is, mainly renal denervation and carotid baroreceptor stimulation, because of absence of evidence of their ability to substantially lower blood pressure and protect against cardiovascular events. But they found these devices interesting because of the failure of drugs to control blood pressure in a number of patients, and so they encourage future studies on the matter. So the backbone of antihypertensive treatment remains antihypertensive drug assumptions. And in this regard, the new guidelines confirm that 5 major drug classes are suitable for the initiation and maintenance of antihypertensive treatment because of the proven ability to reduce blood pressure, from which the beneficial effect of antihypertensive treatment majorly depends, evidence from placebo-controlled outcome trials, and broad equivalence on overall cardiovascular morbidity and mortality between different drugs. And these are, as you know, ACE inhibitors, angiotensin receptor antagonists, beta blockers, calcium channel blockers, and diuretics. So this is a reconfirmation of what previous European guidelines recommended. But the task force asked a rhetorical question, if you wish. This is, if we have 5 effective classes of antihypertensive drugs that can, in principle, control blood pressure in 90–95% of the hypertensive population, how is it that over the years we continue to have low rate of blood pressure control worldwide, that even in Europe blood pressure control is highly unsatisfactory? And the answer to this question given by the task force has been that perhaps the problem originates from advising ineffective drug treatment strategy in the last 40 years, because guidelines on hypertension go back by 40 years. The recommended strategies were increasing the dose of initial monotherapy, which is largely ineffective and may increase side effects. Sequential monotherapy, moving from one monotherapy to another, which is time-consuming and is characterized by low adherence besides being ineffective. And the so-called step care approach, initial monotherapy followed by combination treatment, which is in principle good, but faces the problem of a high level of so-called therapeutic inertia. So, in the face of this, in recent years, there's been very interesting evidence on a number of advantages of starting treatment with a 2-drug combination. Greater blood pressure reduction, reduced heterogeneity of the blood pressure response, little incidence of hypertensive episodes, and a substantial improvement in long-term adherence to treatment and reduction of therapeutic inertia. So this is the major element of novelty concerning treatment of the new guidelines. We propose initial combination treatment in the majority of the patients. And this is particularly important also considering, as you've heard from Brian Williams, that now we place target blood pressure values at a lower level, and therefore a more intense drug treatment and effective treatment strategy is needed. We also recommend to use, whenever is possible, single pill combination therapy because of the evidence that this is associated with a substantial improvement of adherence to treatment. As I said, this is advised in the majority of the hypertensive population. Monotherapy is reserved to individuals with a high normal blood pressure because only a few millimeters of mercury are needed to control blood pressure in these individuals, and this, of course, may be achieved by one drug only. In addition, we recommend to start treatment with monotherapy in frail elderly patients and in very old patients for safety reasons. Now, which combinations? Now, the recommendation is to use a combination of a blocker of the renin-angiotensin system, be it an ACE inhibitor or an angiotensin receptor antagonist, with a calcium channel blocker or a diuretic in uncomplicated hypertension, and in addition, in a number of other hypertensive conditions, such as, for example, patients with asymptomatic organ damage, cerebral vascular disease, diabetes, or peripheral artery disease. But several combinations have been tested in clinical trials with successful reduction in cardiovascular risk. As you can see from this slide, only double blockade of the renin-angiotensin system by the concomitant use of ACE inhibitor and angiotensin receptor antagonist is not recommended. So many other combinations can, in principle, be used, and we have listed and discussed different conditions in which different first step two-drug combination treatment, hopefully in a single pill format, can be used. Different clinical conditions have been discussed in the guidelines, not only with regard to use of two-drug combination as first-step treatment, but also with regard to the entire management. And I believe for the first time, great deal of attention has been devoted to the patient follow-up, which has been somewhat overlooked in previous guidelines. As you can see, there are many, many issues in the follow-up which are extremely important for maintaining successful treatment. And perhaps the most important of all is the problem of drug adherence, because drug adherence is extremely low in hypertensive patients, and this has an ominous effect on cardiovascular risk. And so guidelines devote in-depth discussion on the means through which adherence to antihypertensive treatment can be improved. The hope is that by this, guidelines will offer a contribution to improving rate of blood pressure control in the hypertensive population, and by doing this, step down hypertension from the undesirable position of being the first cause of death and disease worldwide. Thank you.